Welcome to This Explainer. Today, we're diving into one of the most terrifying yet absolutely fascinating medical mysteries in neurology. We're talking about Guillain-Barré syndrome. We're going to look closely at the data and the clinical guidelines to really understand exactly how the human body can just suddenly turn against itself. Imagine waking up one morning with just a slight tingling in your feet, but then, over the next few days, or honestly, even hours, that tingling rapidly escalates into total paralysis, potentially leaving you unable to even breathe on your own. And you know what the craziest part is? This incredibly severe reaction often happens just weeks after you fought off a completely routine stomach bug or a mild cold. So, here is how we'll break this medical emergency down systematically. We'll start with an overview and the triggers, then look at the mechanism of mimicry, map out the clinical phases and symptoms, discuss diagnosing the syndrome, and finally, wrap up with treatment and prognosis. All right, let's jump right into part 1, overview and triggers. It's a true post-infectious mystery. So Guillain-Barré syndrome, or GBS, is pretty rare. The incidence is right around 1 case per 100,000 individuals. But what's really interesting here is who it targets. It actually affects adults more frequently than children, and it hits men slightly more than women, at a ratio of about 1.5 to 1. And if we're looking at Western countries, the most common variant you'll see is acute inflammatory demyelinating polyneuropathy, or AIDP for short.
But here's where the real mystery begins. Roughly 2/3 of GBS patients experience symptoms of an upper respiratory or gastrointestinal infection up to 6 weeks before any neurological symptoms show up. The most common culprit? Campylobacter jejuni, which typically causes gastroenteritis. But it is definitely not the only one. Cytomegalovirus, Epstein-Barr virus, influenza, Zika virus, and even SARS-CoV-2 have all been associated as triggers. The exact causal connection is still being actively investigated, but we do know that these pathogens somehow set off a truly devastating chain reaction.
Which brings us to part 2, the mechanism of mimicry, or how the body gets betrayed. The absolutely crucial concept to grasp here is molecular mimicry. This is the core pathophysiological driver of GBS. Basically, an infection triggers your immune system to produce a humoral response. But because certain structures on the bacteria look incredibly similar to the structures on your own peripheral nerves, they literally mimic them. Your immune system gets confused. It starts generating these cross-reactive autoantibodies that turn around and attack your own tissue. Let's look at how this actually plays out. You've got Campylobacter jejuni with its bacterial fragments. Your antigen-presenting cells spot this and immediately activate T cells and B cells. The B cells undergo isotope switching and pump out IgG antibodies that are meant to fight the bacteria. But here is the problem. The ganglioside structures on your peripheral nerves' myelin sheath and nodes of Ranvier look practically identical to those bacterial fragments. Because of that, those antibodies cross the blood-nerve barrier and attack the Schwann cells and the myelin sheath. Macrophages and complement proteins join the fight, leading to immune-mediated segmental demyelination and axonal degeneration. The wires of your nervous system are quite literally being stripped of their insulation. Moving on to section 3. Clinical phases and symptoms. We call this the ascending wave. The classic sensory motor progression kicks off in phase 1, where the patient starts experiencing tingling in their hands and feet. This is a paresthesia that often presents in a classic stocking glove distribution. By phase 2, the patient might struggle to even rise from a chair because of progressive flaccid paresis. GBS typically features bilateral ascending weakness. This means it starts in the lower limbs and literally climbs upward, often being way more pronounced in the proximal muscles. By phase 3, if a doctor tests their reflexes, they're going to find hyporeflexia or even complete areflexia. But unfortunately, that wave doesn't just stop there. As the disease ascends, we hit phase 4, where respiratory muscle involvement makes strict monitoring absolutely crucial. Because the autonomic nervous system is under attack too, patients can experience wild blood pressure fluctuations, cardiac arrhythmias, and urinary retention. In phase 5, the respiratory muscles can fail entirely, meaning the patient will need mechanical ventilation. Finally, after weeks or sometimes months of this, patients reach phase 6, the plateau and eventual recovery, as the body very slowly repairs that damaged myelin. I want to pause for a second and highlight this really critical clinical pearl from the medical literature. It notes that GBS can affect respiratory muscle function, and life-threatening respiratory failure occurs in approximately 20% of patients and can develop within hours. Let that sink in. This isn't a watch-and-wait kind of situation. This is an acute medical emergency that requires constant bedside pulmonary function tests to check vital capacity and inspiratory pressures. Building on that, the sources give us another huge insight for triage.
If a patient presents with bulbar palsy, so dysfunction of the cranial nerves that affect swallowing and speech, or if that weakness has rapidly reached the upper extremities, or if they have autonomic dysfunction, well, their risk for rapid respiratory failure just skyrockets. These are the patients who need to be in the ICU for monitoring immediately.
Now let's tackle Section 4, diagnosing the syndrome. We'll look at the criteria and the clues. The standard diagnostic criteria for GBS strictly require progressive muscle weakness in more than one limb, right alongside areflexia or hyporeflexia. But clinicians are also hunting for supportive features. They want to see symmetry in the weakness, cranial nerve involvement, especially bilateral facial nerve weakness, and crucially, the absence of a fever. On the flip side, if there is persistent asymmetry or a very sharply defined sensory level, well, that casts some heavy doubt on it being GBS. Now, one of the most fascinating diagnostic tools we have is analyzing the patient's cerebrospinal fluid, or CSF. It might actually look normal in the first week, but eventually, a classic hallmark of GBS emerges, called albuminocytologic dissociation. So what does that mean? It means there are highly elevated protein levels in the spinal fluid because of the intense inflammation of the nerve roots, but the white blood cell count is completely normal and low. High protein, no cells. It is a massive, incredibly helpful clue for doctors. Yet, even with all these advanced tests, the literature leaves us with this brilliant reminder. Other causes of an acute neuromuscular paralysis should be excluded via the history and examination rather than investigations. It's so true. A skilled physician can very often rule out mimics like botulism, diphtheria, or spinal cord syndromes just by taking a careful history and doing a thorough physical exam. And in these cases, that saves precious time. Which brings us to our final part, Section 5, treatment, monitoring, and prognosis. So active treatment is all about cleaning up the mess the immune system made. The two primary options here are intravenous immunoglobulin, or IVIG, and plasmapheresis. Both of these treatments actually shorten the duration of mechanical ventilation and significantly improve the prognosis. IVIG works by basically flooding the body with healthy donor antibodies that neutralize the harmful autoantibodies. Plasmapheresis, on the other hand, physically filters the toxic autoantibodies right out of the patient's blood. Generally speaking, IVIG is preferred for children and for adults who have cardiovascular instability. Now, if you know a bit about autoimmune diseases, your absolute first instinct might be to give steroids to calm the immune system down. But check out this clinical pearl. Glucocorticoids are not recommended for the treatment of GBS. The data actually shows they simply have not been proven to hasten recovery or improve the prognosis for this specific disease. It's a super common misconception, but the source material clears it up definitively. To kind of summarize the patient's journey, let's trace the chronological arc. Up to 6 weeks prior, there's a minor GI or respiratory infection. Then those neurological symptoms hit, peaking in severity right around the 2 to 4 week mark. After they hit that plateau, the long road to recovery begins. Fortunately, about 80% of patients will regain the ability to walk unaided by 6 months. However, we cannot understate how serious this is. 3 to 7% of patients will tragically die from complications like severe respiratory muscle paralysis, sepsis, or a pulmonary embolism. Which really leaves us with a profound mystery. With molecular mimicry literally turning our highly evolved immune systems against us over something as simple as undercooked chicken or a mild virus, what other everyday pathogens might hold the keys to understanding the world's rarest autoimmune disorders? Thank you all so much for watching this explainer and exploring this incredible topic with me. If you found this visual breakdown helpful, make sure to follow the channel Mid-Medicine for more structured, graphic-driven medical explainers. Until next time, stay curious.